Hey guys, this is B McCammon, also known as Brian. Today I'll be presenting glenohumeral shoulder subluxations and dislocations. So some basic anatomy. The image on the left is just basic bone anatomy. You can tell just by looking at the shoulder and the glenoid cavity. It's pretty unstable joint. Then the image on the right, you can see the soft tissue, ligamentous, and cut tendon structures that make up the glenohumeral joint, which helps stabilize the joint itself. Some pathology. We've got shoulder dislocation is just a complete dislocation of the humeral head and the glenoid fossa. And you can tell with the x-ray image on your left that the dislocation is at that joint. You can tell it's pretty painful. Shoulder subluxation is just a partial, incomplete version of shoulder dislocation. The humeral head is actually still in contact with the glenoid fossa, but it's just so unstable that, it needs to be put back in place. And I actually had multiple sources that mentioned that shoulder dislocations and subluxations occur anteriorly. 90% of those are anteriorly. Mechanism of injury, we've got shoulder dislocation and subluxations. Most commonly, both of those happen through trauma or instability in general. But dislocation, the humerus is often forcibly removed from its socket in the glenoid fossa, and the shoulder is pretty vulnerable to dislocation when the shoulder is in abduction and external rotation, and the shoulder subluxation is commonly caused by instability with weakness of rotator cuff or laxity of glenohumeral ligaments. So that being said, the humeral head would ideally slip out of the glenoid fossa easily. Some signs and symptoms, we have pain, obviously, and then the athlete may refuse to move the shoulder in any direction, fearing that it may make the shoulder worse. There are some muscle spasms, there are some ecchymosis, swelling, obvious deformity. Believe it or not, an athlete could experience nausea, vomiting, lightheadedness, or weakness. This is due to the vagus nerve being stimulated, which blocks the adrenal response. Some predisposing factors, prior shoulder subluxation and dislocation. So say if you previously had a subluxation or dislocation, you'd be more prone to another one. Contact sports are a big one, primarily in adolescence, or sometimes just instability in general with ligamentous structures or weak stabilization muscles. Some differential diagnosis, we have a few: bicipital tendonitis, clavicle fracture, rotator cuff injury, swimmer's shoulder, also known as impingement syndrome, labral pathology, and then some considerations: there could be a glenoid labrum tear, or there could also be a Hill-Sachs lesion or fracture. Those of you that don't know what that is, it's basically a depression fracture in the head of the humerus. That's often resulted in dislocations when there's forceful impact with the rim of the inferior rim of the glenoid and the humeral head. Some special tests, I'll go and show you some videos of those. We have the anterior apprehension test, and if that test is positive, then we'll move on to the relocation test. And then we have the posterior apprehension test and the anterior posterior drawer test, the sulcus sign, and the Fegan's test, also known as the inferior drawer.
Hi, and welcome back to PhysioTutors. The apprehension test is used in the assessment of shoulder instability. Hedges et al. From the year 2012 rate its sensitivity at 66% and the specificity at 95%. Coles et al. Include the apprehension test in their shoulder impingement assessment algorithm, but they are primarily looking at the location of the pain that is elicited during this test. If the patient has anterior shoulder pain, This gives an indication of a subacromial impingement, whereas posterior shoulder pain during the apprehension test gives an indication of an internal posteral superior glenoid impingement. To conduct the apprehension test, have your patient in supine lying position. Then abduct the arm to 90 degrees and add maximal external rotation in the glenohumeral joint. A positive test is pain or the fear of luxation. Alright guys, this was the... Hi, and welcome back to Physio Tutors. Hedges et al. From the year 2012 have evaluated the relocation test with a sensitivity of 65% and a specificity of 90%. With regards to the shoulder impingement algorithm from Colts et al., the outcome of the relocation test allows you to differentiate between primary and secondary impingement. If the test is positive, so pain diminishes during the test, this means that the impingement is secondary and pain is mainly elicited from excessive anterior translation of the humeral head. A negative test, meaning that pain persists, gives an indication of primary impingement where the symptoms are not dependent on the arthrokinematic position of the humeral head. The relocation test is a subsequent test to a positive apprehension test. To perform it, bring your patient in the apprehension test position until pain is elicited and add a posterior glide in the glenohumeral joint. The test is positive if any elicited pain during the apprehension test disappears. Alright guys, this was the relocation test. If you like this
here, because what the posterior apprehension test does is it checks for posterior dislocation of the shoulder. But again, if it's not positive or if it's not negative, it doesn't necessarily mean anything. This is just to check to see if you have pain. So if he does have pain with this, it doesn't necessarily mean he's had a dislocation. It can mean his shoulder's unstable. It can mean there's some impingement going on in there. It can be positive for a bunch of different things, even though it's specifically for a posterior dislocation test. So I always say kind of take it at face value, take it with a grain of salt. But if I did this side and there was no injury, he shouldn't have any pain at all. So if you're getting pain with it, it just kind of helps you narrow it down to what's going on. So I did this side and there was no injury, he shouldn't have any pain at all. So if you're getting pain with it, it just kind of helps you narrow it down to what's going on. So for the posterior dislocation test, or that posterior apprehension test, what you want to do is bring his arm up to about 90 degrees. You can just have him kind of place his hand over on his shoulder so it's resting like this, because you want him to be comfortable. If he wants to put his legs all the way out, he can. They don't have to be propped up. You just want him to be comfortable. So when you get in about this position, the next thing you want to do is put your other hand underneath that scapula or shoulder blade to stabilize it, because you're checking for the joint. And if I just push this way, it's going to move together with that shoulder blade and that humerus bone. And we want to check to see if it's moving separately. So I'm just going to put my hand under that shoulder blade there. Pretty comfortable, right? And so what I'm going to do then is I'm going to push downwards posteriorly, and then I'm going to do coming in across, horizontally abducting, immediately rotating. So as I'm pushing, I'm just kind of moving it around in there. And what I'm looking for him is if he has an owie face or an apprehension face, because it means it's hurting. Sometimes they'll tell you that they feel like it's about to dislocate again. So that's usually a positive sign. So stabilizing that scapula, pushing down, pulling in, immediately rotating. So if he's looking like it's not so good, don't keep pushing. That's a positive test. And then that usually is a sign that there's some kind of instability in that shoulder, but not necessarily that dislocation, but it could be. So that
The anterior drawer test of the shoulder is used to measure the amount of anterior joint play or laxity in the shoulder. What you're going to do to perform this test is you're going to hold with your distal hand. We're going to hold the bicondylar axis of the humerus. That's going to allow us to really control his arm in space. I can move it in any direction real easily with one hand grip. My proximal hand is going to come up and really palpate right on the humerus. It's important that you get the humeral head between your thumb and your finger, and you're not just blindly doing it on the humerus. You want to do it right on the humeral head. In this position, I'll bring him up to 90 degrees, and I'm going to glide the humerus anterior and back to neutral in this position. Now notice I'm performing at an anterior medial plane. That's important because the plane of the glenoid in the scapular plane is anterior medial. So you want to perform your drawer in that position to make sure that you're getting true translation that's congruent with the line of the joint. Drawer test is used to check for the amount of posterior translation of the glenohumeral joint. To begin, we're going to hold the bicondylar axis of the humerus, and with my proximal hand, I want to get right on the humeral head. It's important that we get on the humeral head between my thumb and my fingers, because if we're just blindly doing it on the humerus, you really don't appreciate the amount of translation. So I'm going to get right up on that humeral head. We're going to come to 90 degrees, and I'm actually going to horizontally adduct a little bit more than I normally would, so that way I'm sure that when I perform my posterior translation, I'm clearing the glenoid rim. If we're too low and we're just going posterior, I'm going to hit the glenoid and it's going to be a hard end feel. We have to come up and translate posterior lateral to assure that we're following the scapular plane of the glenoid. So we're going to get him right there. We're going to perform that posterior translation, and we can see the amount of posterior laxity that he has.
A positive sulcus sign can be an indication for inferior shoulder instability or glenohumeral laxity. Be careful though if your sulcus sign is present on both sides, as this outcome is not as clinically relevant like only unilateral laxity on the affected side. To perform the test, have your patient in standing position with relaxed shoulder muscles. Then grab your patient's arm distally to the elbow joint and pull the arm distally. The sulcus sign is the appearance of a little dip under the acromion or the feeling of subluxation, which is not the case in this patient. Okay guys, this was
the Fagan's test. Can be used to test for inferior glenohumeral instability. Apply an inferior anterior force through the humeral head. A positive test is indicated by excessive laxity or apprehension.
Alright guys, so that was the 7 special tests for shoulder instability. And now we're moving on to management and treatment, non-surgical. We've got traumatic and atraumatic, traumatic being like a direct blow, atraumatic being just poor instability in general. As far as traumatic injuries go, a common way to manage it is police. Passive or active exercises would work, and we got to strengthen the shoulder girdle muscles as well. Proprioceptive training is also a good idea to improve dynamic shoulder stability. Arm sleeves or arm slings would work well. Narcotics and NSAIDs would help relieve the pain. And a good idea would be to avoid postures leading to recurrent subluxation. And as far as atraumatic goes, progressive strengthening of rotator cuff, deltoid, and any other scapular stabilization muscles would benefit to prevent recurring subluxations and dislocations. And as far as surgical procedures go, there's 2 types of surgeries they could do on shoulder instability or dislocations. One of those is open surgeries, and the other one is arthroscopic. Arthroscopic surgeries have a shorter operative time and less hospital stay, and they're also cheaper. However, an open surgery may be performed if there are contraindications for arthroscopic surgeries such as Hill-Sachs lesion, since that is a contraindication for arthroscopic surgery, then an open surgery would be necessary. And immobilization and referral, you should refer to your orthopedic or physician if the athlete is unable, or if you are unable to reduce the subluxation or dislocation, or if there's a possible fracture, or if there's a need for a procedural sedation. And an immobilization would be just as tolerated with a sling. Some preventions. The first dislocation and subluxation usually can't be prevented. However, if an athlete does have a dislocation or subluxation, then they can prevent further dislocations or subluxations in the future if they do strengthen any stabilization muscles or going through physical therapy as well. Some Mulligan techniques. Mulligan is possible for shoulder instability. Just keep in mind that Mulligan is actually a joint mobilization, so it is used for ligamentous structures, not necessarily muscle tissue. Mulligan belt and tape could be used for anterior stabilization. Then my Peacott analysis, I had a population of one 30-year-old female, and intervention. She ended up having a dislocated shoulder, and then it was reduced and popped back into place. She had her shoulder immobilized, and then she went through progressive rehab. The progressive rehab aimed to restore full range of motion, proprioception of the shoulder, and strengthen dynamic stabilizers in like the rotator cuff muscles. The comparison was non-operative procedures versus an operative procedure. In this case, it was non-operative. And then the outcome was that she ended up regaining full range of motion and strength. Then the affected shoulder was compared to the unaffected shoulder, and the affected shoulder was eventually tested negative for instability. And the whole course of this took about 8 weeks with the time. So here are my references. Hope you guys like this video. Any questions, go ahead, leave a comment.